is talking about pediatrics and getting a child to the office or to the clinic. I just read a study recently that said, interestingly enough, that it was a study in Jordan, but that 83% of the parents have a conception or an idea that their children's mouths are fine, when in fact we know that that's not true. That a child could have a mouthful of decay and the parent still thinks it's fine, and we have to work on early intervention. So the first slide I have is a patient of ours that says, hey, you have to be kidding or you have to be crazy. I'm not going to the dentist, but it's really something that has to be done. In the United States and around the world, we have a program that says through the American Dental Association, the American Academy of Pediatrics, and the World Health Organization, that everybody needs to find a dental home by the age of 1, which is not difficult, but it's very hard for parents to understand that. So we need to educate a parent and a patient to say, hey, it is important enough. We also need to educate the government that says, hey, we need to get children in because they're going to have all kinds of issues in life if we don't do that and don't maintain a standard of care and a routine. So the objectives of this morning, besides some other issues that we'll get into here and there, because I just go back and forth, is we're going to talk about the prevalence of dental disease. And everybody knows that obviously it is a disease. It's just not like something that just happens. It's a disease process that needs to be taken care of. It doesn't go away. We have to control it. We'll talk about the definition of dental home, like I just suggested. We'll also talk about how we may be able to create a dental home and make people in your country or any place aware that they need to go. If you're not aware that you're supposed to go to the dentist, then the knowledge is wasted. You know, we have to let our patients know and our parents know that it is important, that the mouth is not separate from the body, that together the body and the mouth work together, and if we don't take care of one, we can't take care of the other. We'll also talk about dental neglect. Unfortunately, in the United States and around the world, there are all kinds of issues where people, whether they have the money or not to restore it, there are options, but some parents just let things go, and the poor child is stuck with a lot of decay, pain, and swelling, and all kinds of other issues. And at that particular point, that child really, if he's in school, can't learn. It's impossible to learn while you're in pain. If you have a stomach ache while you're listening to a lecture from an us, it's not doing you any good, because you're paying attention to your stomach and you're not paying attention to what he has to say, or Ibrahim or anybody else. We'll talk about dental disability and what that entails, and we'll talk about risk assessments and the management of decay. All of those processes in together. We're going to talk about anticipatory guidance. What do we do to make sure that the teeth come in the right way? And how do we do that? Do we do a space maintainer? Do we extract? We'll talk about the decay process in the educational issues that arrives. That's with educating a parent. We'll talk about what's medically necessary. We'll talk about the bottom line of fluoride and fluoride supplements, which is essential in the care. You know, in every country around the world, there are different ways that you get fluoride in your water or in a supplement, or you don't get that at all, and that is proven as a classic way to reduce the chances of decay. If we start early enough, then we can reduce those chances. And we're going to learn how to go over how to examine a child. If you're a general practitioner, if you're a pediatric dentist, you understand that the kids are going to cry. If you're a general dentist, you're going to understand that you don't like that, and that's okay. But we're going to try to figure out how to best understand and drown out that noise. I've got 3 girls, 1 wife. I'm very good at drowning out noise. They yell at me, and I just nod my head and tune it out sometimes. And then there are some legal aspects in the United States that we can just gloss over, but there are methods here in the United States that protect the child. There are, we're going to advise on home routines, and we're going to talk about, how to make that routine or that appropriate recommendation to a parent, and how to evaluate a treatment with an infant, and discuss why we refer to a pediatric dentist. There are certain times that a general dentist is capable of doing the work, and there's certain times that a general dentist either doesn't want to or should refer out, when to refer and when not to refer. I'm not exactly sure where we stand as far as who is listening online today, but there are various amounts of issues that can occur in that. And again, as I said at the beginning, if you send me your email, I will send you my email, and I will go back and forth and help you in any way that I possibly can. We'll also talk about taking some radiographs, some x-rays. Are they necessary? How often should I take them? And for a general practitioner who just throws up their hands and says, oh, how am I going to do that? We'll discuss some of that stuff. And we'll talk about, in the United States, the importance of mandatory state health exams, which is an issue that has been very topical here and around the world, whether or not you mandate that children go to the dentist before they go to school. And then we'll talk about a little bit about the benefits of xylitol. I don't know if you guys are aware, but most people are, that xylitol is a sugar substitute, a naturally occurring substitute that will help reduce the chances of decay. So now we have this little child who you just told that little child that you're taking me where? And this is a little child that I don't want to see, and you possibly don't want to see. But we have to prepare that child ahead of time for the visit to start out with. Again, hold your questions and then just send them to us as we go, and we'll get to those all at the end. This is basic stuff at the beginning, but this is all stuff that leads up to more important stuff as we go further along. The dental problem, or the prevalence of dental disease, is fascinating, whether it's in the United States or around the world. The percentage of children between the ages of 5 and 19 years old in the United States is 17.5%. That gets you almost 1/4 of the children in the United States have untreated dental decay. In many parts of the world, that percentage goes up to 30%, 40%, 50%, or even 60%, depending on where you are. The percentage of children from 2 to 17 that have gone to a dentist in the past year in the United States is 83%, which is relatively high. In other countries, you could have 20%. How do we get that 20% to be up to 80% is the issue. And there are recommendations and programs that are out there that we need to investigate, and whether it's in Syria or Egypt or Dubai or any place in the Middle East or United States or Europe, there are different approaches to getting that dental visit. First of all, we have to start with education, but we'll get a little bit further into that. And approximately 23% of the children between the ages of 2 and 5 had dental cavities or had dental caries in their primary teeth. That means that a 2-year-old who has never been to the dentist and hasn't followed the dental home regimen is starting out life at a disadvantage, because they haven't had exams and had that decay taken care of. It is so much easier to take care of the decay early on. As you all know, it's much easier to take care of a class 1 or even a class 2 restoration compared to a pulpotomy, a stainless steel crown, and anterior decay and things like that. So prevention and early intervention is essential. How do we get that is a major problem. Whether it's the United States or any place else in the world, it's education. We need to educate. We need to sit there and say, hey, what can we do to increase that education? And if you look at this next slide, the United States is just our example, but the dental decay rate is up to 36% if you look at the top slide. And then we break that down into ethnic backgrounds, which are non-Hispanic whites, have a lower cavity rate than Hispanic or Black or Asian Americans or even Native American Indians, which have a higher rate. So every ethnic community has a different type of rate. Every ethnic community has different values and different areas of concern. Some aren't educated to get that taken care of, which is our goal, and some just disregard it because they think it's a natural part of life. So you can see that down with the untreated dental decay, that 14.3% of most patients have untreated decay, and that those rates in the ethnic variations varies. So in Syria, you may have, ethnic populations that have higher rates than others. And it doesn't necessarily go with education, because people can be exceptionally well educated and still have those same values than somebody that is uneducated. So how do we create that correction of a problem is by educating. We have to start educating the parents. We have to start educating the students. We have to start educating the government. We have a whole group of people that we have to educate. In my office, we go out into the public, and we will sit there and we will give lectures or tours to nursery schools. We will go to doctors' offices to promote good oral health. February, the month here, is Dental Health Month. So there are all kinds of programs going forward. If you look on the website of the American Dental Association or the American Academy of Pediatrics or the European Academy of Pediatrics, or even your academies of pediatrics, there are all kinds of programs, there are all kinds of resources that are out there that will help get that program going. But the dental home, as described by the World Health Organization, is a relationship between the dentist, the patient, and all the oral health care deliveries in the world, from comprehensive to family-centered education is exceptionally important. So you can go to the dentist as a family, and you should go to the dentist as a family. But if someone doesn't tell you that that's what you're supposed to do, then you don't know that. If I had a little daughter, if one of my daughters was walking into the wall and missing the door every day, I might say to myself, hey, she has an eye problem, and maybe I need to take her to the doctor. But if my pediatrician early on in life says, hey, these are steps that you take to get to take care of your eyes, your feet, your posture, your brain, your health. If these are the steps that you take and you get to the dental office by the age of 1, we can prevent. So the obligation is us to try, but we have to be partners with the pediatricians, the physicians, and the state health or the country health officials. And they need to establish a program, and it's hard to do. So, and if you have a country that doesn't have a lot of money to do that, it makes it even more difficult to do. But it's not that hard to promote dental health care by taking it to outreach programs, by going to a nursery school, or going to an OBGYN, an obstetrician's office, and saying, hey, mom, you've got pregnant parents here. Why don't we educate them ahead of time? There are all kinds of resources. As I said to Ibrahim before, I posted this morning a post about nitrous oxide and the use of nitrous oxide. And we can get into that a little bit later. But my point is I print out a piece of paper. I explain to a parent. A physician can explain to a parent, this is what they're supposed to do. And a parent sits there, and you've probably all had this before, or you will have this, or a patient will sit there and they will shake their head. Do you understand what I'm saying? And they shake their head, they shake their head, they shake their head. And they walk out of the office and they say, what did he say? It's just like me getting directions to go to a store. I stop someplace, I get directions, and they say, go this way, go that way. and I drive out of the parking lot, and then I ask my wife, what did the guy say? How do I get there? Because we just didn't listen. So handing them a piece of paper that they can take home in easy language, we bring the language down to a second grade level so that people can understand it in simple terms and say, hey, these are the following steps, and these are what you should be doing. And these are some ideas that we can do. That's a piece of paper that can be printed out by a physician, by you, by fax, by posts on websites, because all of your offices or all your clinics should have websites and should have, how do I do whatever it is that I'm going to do. So the dental home is supposed to be established no later than 12 months of age. And that includes a referral. So how do we do that? That goes down to the doctor. The doctor has to say, hey, your teeth are important. We'll get to how we get there, but the doctor has to help us. The pediatrician has to help us and say, how do we get there? They have to say, hey, now is time to get to the dental office. We want to educate you. I know it says that the dental home starts no later than 12 months. I prefer starting at 6 months. And everybody will say, well, they don't have any teeth at 6 months. And you know, why would I take my child to the dentist at 6 months? And you're correct. Most of the time they don't have teeth at 6 months. But if I get you early enough, we can prevent. The bottom line is, at this particular point, if I educate you before the teeth come in, then maybe you will follow half of what I say and reduce the cavity rate or the decay rate. You know, we go over diet, we go over home care, we go over the day that the baby pops out, and the day that the baby is born is a day that you should be wiping around the gums and getting that baby used to it. Because how many times do we have people come in and say, well, my child doesn't want to brush his teeth. Now, if the parent doesn't brush his teeth, the child, I can't expect the child to brush his teeth, because that's a habit that the parent hasn't taken care of themselves. So we want to try to, again, educate them, but we have to start early. We have to get in there and say, hey, we need a program, and there are state agencies or country agencies that will help to spread the word on that and promote dental health. If it's not us, there are toothpaste companies that will do that, Colgate or Crest or major companies that are throughout Ream in India. There are all kinds of companies that help and have all kinds of information that is for free that will help you to get that to a parent. And again, I think that if you start in the obstetrician's office, you are ahead of the game, because maybe they will educate, and maybe they will give out brochures, and maybe the parent will say, hey, I think I need to do that. And again, if you start, the baby can kick, scream, and be miserable. I would rather my child kick, scream, and be miserable and have no decay than to kick, scream, and be miserable and have a sedation. So there, you know, again, it's preventative, but some of it's cultural. So we have to sit there and say, hey, you know, we hear in the United States, well, my grandparents didn't have teeth by the time they were 20. My parents didn't have teeth by the time they were 20. So it's just natural, but that's not true. You know, you really have to work on it. And it's hard to get that idea across to a culture of people that has been generations and generations. Again, the concept came from the American Academy of Pediatrics, and they defined a medical home starting early on, but they also talked about pediatric healthcare and supervised quality healthcare by all practitioners, all specialists, whether it's a general practitioner for teeth or a doctor, an orthopedist for, you know, spine issues or whatever issues arise. This doesn't even take into respect with people with special needs. That's another issue. Again, we'll get into that a little bit later. It's been shown, obviously, that healthcare provided to the patients early on is the most effective and less costly to the hospitals and to your clinics. So if we can get in early enough and start early enough, we can maintain a child that is healthy and will reduce the costs. So a government or a country needs to understand that, and that's part of our job, is to make them understand that if we spend a little bit of money, even if we don't have a lot, spend a little bit of money to educate, we will reduce the costs of treating. I used to run a state in here, the state of Arizona. I'm from Arizona. The state of Arizona's Medicaid program, and that took care of all the poor and the indigent patients in the population from 0 to 18. And that took care of them for free. And it was still an issue because we had to get them to the office. So it's a problem. It's a universal problem. Research supports all of the efficacy of prevention and professional care early on, from caries, risk assessments, by assessing that child early on and saying, hey, here's a problem. And what do we do to correct that problem or make sure that problem doesn't exist further? And what do we do now that we have a problem? How are we going to make sure that those permanent teeth come in? And how are we going to make sure that those teeth are stable? And how are we going to get them to come in on a periodic basis to make sure that they come every 6 months? Again, you know, obviously, if your clinics are set up, a lot of our clinics here are free, and there are ways to get care. There are private clinics, private offices. There are dental schools that take care of children. There are hygiene schools that take care of children. There are free offices that will do care for free. So there are ways to get that process out there. We'll go back one. The establishment of the dental home ensures basically that a child will get routine care, appropriate preventative care, and create basically a lifetime of smiles with pretty much ease. It's, again, we all know it's not complicated if you start early enough. So the AAPD, the American Academy of Pediatric Dentists, which is a great resource. So if you ever have any questions, there are plenty of resources that are out there that will be able to explain processes and make things easier. The American Academy will have a section on composite restorations or stainless steel crowns or space maintainers. There are books, and I'll show you at the end. There's a book that I helped edit recently that is a great guide for a general practitioner to go through the book and understand what it is that they need to do, because it was geared to the general practitioner who really doesn't want to do kids, but should have some fun doing kids to begin with. So basically, comprehensive continuous care in a family setting where everybody can go together, whether they go to the clinic together as a family or they go individually at certain times, but you want to have a group care so that people understand and the children see, hey, mom and dad are going, so I think it's appropriate that we go at the same time. And that was all tried to be modeled by the American Academy of Pediatrics, having a group-centered office or a group-centered clinic or a school that takes care of everybody. If everybody goes together, everybody's maybe a little bit happier together, but we're all working for the same goal. The same thing is set with the American Academy of Pediatric Dentistry. And again, if you go online at that, you will see the periodicity schedules that are out there. Kids with high risk, kids with low risk, whether or not, you know, the frequency of the appointments. Everybody is an individual. Every child is an individual. Everybody has its own schedule. I have 3 girls. They all are on different schedules. So the bottom line is, every child needs to be looked at, or every adult needs to be looked at. Some adults don't need to come back and have their teeth cleaned every 6 months. Some can get away with it for 6 months, or some can get away with it for a year. You know, the point is, how do we make that important enough to people? That's hard work. We do need to do comprehensive assessments for oral diseases and conditions, which means that somebody has to sit down and take a look at that child somewhere along the line. The pediatricians don't get very much in education. And if they do, they get a month of teeth, and they get, you know, 8 years of education on the rest of the body. So they really don't have an idea. So we have to educate them. Not only are they looking at growth and development, but they should be looking for possibly, you know, obviously they just go right by the throat, the teeth. They don't even look at the teeth, and they go right by the teeth and go to the back of the throat, and they're looking at the tonsils. And they're not looking for oral systemic problems. And there are a whole group of oral problems that start in infancy. If you look at what's happening today in the coronavirus that's out there, there have been many children that in the United States, which is, you know, obviously where I am, that have had issues with the coronavirus, or a variation of the coronavirus, where they will have rashes, they will have fever, they will have breathing issues, and what they were calling Kawasaki's disease a long time ago, that is Kawasaki's disease. They were mistaking that for the COVID for Kawasaki's, which is treated differently. So, you know, having the knowledge from a practitioner standpoint, or having the dentist help the doctor understand what it is that they need to do is essential in creating a good environment and a good working relationship with the doctors. You know, again, individualized preventive programs based upon the risk assessment for the kids and the periodontal rests as the kids get older. There are guidelines that say, hey, if you are a high risk, and in Syria, my understanding is that you have many more high risk patients than we have. And that's okay, as long as you understand and we educate a parent that says, hey, there are many high risk issues that demand that you have more prevention oriented programs than somebody that doesn't. You can have a little kid that comes in and has never had a cavity. Again, I've got 3 kids. 2 of mine have never had decay, and one has, you know, a moderate amount. There is a hereditary predisposition towards that. There's a dietary predisposition towards that. I blame my wife's side for my daughter having decay, because her hereditary line gave her more dental problems than my side. So I'll take credit for my 2. She takes credit for the other one. But the bottom line is different stages and ranges go, and every child, again, is an individual. Anticipatory guidance and monitoring the growth and development is essential. And, you know, if you don't see a child until they're 10 or 11 and they had a crossbite in the anterior or the posterior because they had a thumb habit or a finger habit, that could have been corrected early on and allowed that child to develop and to grow in a straight pattern. If you don't take care of that problem early on, you're going to have all kinds of major issues. I'm throwing the cost aside, but prevention of a permanent tooth that's coming in crossbite can be corrected even with a stick, with a popsicle stick, where you will push on the teeth. So we can sit down, and we really need to take a look at what's happening with growth and development. And again, if they're not getting to you, or they're not getting to the clinic, I really expect the physician to do their job. I mean, it sounds cruel, but if I don't see them and they're not getting them to me, I have an issue with that. And I think that the medical world needs to understand that we all have to work together, and they have a responsibility as well. We have to also have a plan for acute trauma. You know, obviously, you know, we get called all the time on my kids just fell. What am I going to do? How am I going to take care of that? Who do they call to? Where do they go? They go to a hospital, or they go to their doctor. And if they don't have a dental home, if they don't have a dentist that they go to, whether it's the clinic, again, or the hospital setting or a private clinic, if they don't have, and they're not comfortable in going there, then there is no plan for trauma. And that child will suffer, you know, with broken teeth, anterior teeth with pulp exposures, trauma in a bike accident where the jaw is broken, and they may not do anything for a while, or that people just don't know how to take care of that. So if I start early enough, and I as a dentist, maybe I can't handle that trauma, but a parent can certainly go to the clinic and say, okay, I've been seeing Dr. Anas, or I've been seeing Dr. Ibrahim, or Dr. or whoever, and he's my dentist. He can point me into the right direction as to where I go. So a parent and a child will do substantially better if they go to an office. Again, I don't care whether the child kicks, screams, and is miserable when they're young. Eventually, they will like us. the earlier, the better. So if you go to a situation, if you don't feel well and you go to your doctor, and your doctor is somebody that you trust and you like, you will be much more receptive to treatment. So I go to my doctor, I have a stomach issue, and he said, look, I have to do an endoscopy. I've got to go down into your stomach and I've got to do a biopsy or whatever it is. But I trust him. Even if it's a bad experience, it's not as bad an experience as it would be if I went to a doctor for the first time, or I went to the emergency room. The emergency room is the worst place to go because the residents don't have a clue. Most hospitals don't have dental clinics. They may have an oral surgeon on staff, but the oral surgeon doesn't know what to do. And sometimes what they do is not the appropriate care. So by having a dental home, at least there's a phone and a number or a clinic that they know that they can show up if there's a problem. And again, I used to, in my private clinic, I used to go out and everybody had my phone number. If they had a problem, they could call me. Now with your iPhones and regular phones, they can take a picture. I just got a picture the other day of a kid that fell and chipped a tooth, and they happened to be in another state. And it was a minor chip and everything looked fine. So I said, no, you don't need to, rush to the dentist, soft diet, or whatever it is that I chose to do from a treatment standpoint. But they felt comfortable enough to call me. Being in a situation, especially in a foreign place where you don't know anything or know anybody, it makes it even more difficult. But if you have a phone number and you have a clinic and you have a place that you can go, that you call home, where everybody is sort of, your family, you will be treated better and get better care. Basically, we want to give out the information about proper care to the children's teeth and gums, and we talk about diagnosis and treatment plan of the disease. And early on, and early treatment plans are much easier to take care of than complicated stuff. We'll get a little bit further into that when you have kids, in your case, where maybe 60% of the kids come in with huge amounts of decay. What do you do and how do you take care of that is a different story. We also have to go over diet. The bottom line is, you can talk all you want, but if the home care and the diet is not very good, that doesn't help us. If they're eating a lot of carbohydrates or they're eating a lot of sugar, you obviously know all of this stuff. But the point is, what can you do? There are better solutions to taking care of that diet. We recommend here that children, obviously, there's no reason for children to have juice, because juice has 100% sugar in there. If you're going to do it, here's my water bottle. If you're going to give your child a juice, you water it down, 80% water and 20% juice, and that's it. Every culture has its own problem, issues. There are children that will drink tea, sweet tea, and they'll put 7 sugar cubes in a sweet tea. That's not obviously good for the teeth. You know that, I know that. The parents don't know that. And if we haven't educated them, that's part of our responsibility. But diet is very, very difficult. And kids today who are off by themselves, who are eating whatever, they go to a friend's house and they'll eat sticky, gooey, gummy foods or gummy bears or the stuff that they sell in the market. You have to make choices, and you have to help advise those children and the parents to make better choices. Can you stop it altogether? No, you can't. I can't stop it with my kids, but you can say, hey, if you're going to eat that chocolate chip cookie with a lot of sugar and chocolate in there, maybe you should brush your teeth afterwards. But teeth have to be important. So we have to still make teeth important. We also have to sit down and say, I don't know who's listening all on today's call, but if referrals to a dental specialist, a pediatric dentist or a pediatric oncologist or anything that's there is very, very important. Because just because you can't handle that doesn't mean that it shouldn't be handled. And there are a lot of general dentists in the United States that will say, don't come back until the age of 3 or 4. We don't need to see you. Everything is fine. And they keep playing, play that game because they don't want to take care of the child. The point is, somebody needs to take care of that child, because by the time they're 4 years old and they've taken care of, they haven't come to the dentist, they're coming with all kinds of major issues. So education to everybody, again, whether it's any healthcare worker, whether it's the dentist, or whether it's the obstetrician, or whether it's the hospital emergency room, or whether it is the school nurses, or school or the teachers, whatever you can do to educate those people will help get that process going. That's a hard road. I help institute, and I'm working with this in I think in Dubai and in the Maldives and maybe in India, to set up some programs in those countries where we have a fluoride varnish program. We'll get into fluoride in a little bit, but a fluoride varnish program for preschoolers. And then we get into a sealant program for primary schoolers. So people go into the schools and put on fluoride varnish, or people will go into the schools and put on sealants for those teeth, for those children who can't afford treatment elsewhere, or get to a clinic, or have no idea what that stuff is, but that helps to prevent. And again, we try to educate them, and we want them to grow up to be an adult with minimal amount of problems. Referral at any age is determined by the patient, the parent, and the pediatric dentist. Everybody's got to sit down together and say, hey, where do I go? What do I do? And again, having somebody that you can talk to early on, whether it's the general dentist or not, is essential, because we have to sit down and say, hey, what can we do to help educate and point that kid into the right neighborhood. So again, obviously we need to create awareness. And I know a lot of this is repetition, and if there's students that haven't done pediatric dentistry before, or dentistry in general, because you're going through a program, you have to understand that these are concepts that even though we all learn them in school, that doesn't necessarily mean that everybody does them or everybody follows through with them. So how do we reach the parents? We have to reach the parents, like I said from before, early on. And that starts in the medical offices, the preschools, the daycare centers, the obstetricians, the people that are delivering the babies. That is the most important. When here in the United States, oftentimes the mom gives birth, and the hospital will give a whole package of diapers and formula and some information and things like that to a new mom. Which is great, because it's all donated, and obviously they want you to buy their diapers or whatever it is, but it's a care package that goes to them. Never do they give you anything that has anything about teeth in there. So we've put together a kit where if you go to the hospitals or you do community outreach, so our dental students will go to community outreach hospitals and give lectures to expecting parents. There are groups in a lot of hospitals that will say, we have mommy and me or mom and me programs for little ones, or we have programs, baby universities that are out there that we've started, or you will give to the nurses, the delivery nurses, some handout papers to give to educate a parent. They need to start on day one to get in there and brush the gums, even though there's no teeth, obviously. The more times you are in that baby's mouth, the better off that baby's going to be, and the more consistent home care will be. And that's hard, but that's something that we have to at least try. And if we break through and we get 20% more than we had before, then we're 20% further along the line. It takes a long time. It's been taking the United States a very long time. It's taken England a long time, or other countries a long time to get along that path. You guys are in a different phase, but you'll get there. It's just going to take some time. And again, having some programs that are out there that you guys can do and learn. When I teach, part of our program is an outreach program, again, where students will go out and go to nursery schools or daycares or first grade, second grade, primary school, and say, hey, here's what we need to do. If kids hear it every year, they'll go home and start telling their parents that, Mom, I need a toothbrush. We give them a toothbrush, but I need toothpaste or whatever it is. If kids keep hearing it, they'll go home and keep asking. So, if we can't educate a parent, maybe we can educate a child. Here's another kid who's you just told him he's going to the dentist, and it's saying, I don't think so. I don't want to go. Sometimes you have to be a parent, and sometimes you have to do those things that you may not want to do. Unfortunately, they're kids with major medical problems that parents, don't necessarily go, but they will go to if the doctor says that they have cancer for some reason, or a major issue where they need to go to the hospital every week for a year, they will do that. They don't necessarily listen to us. They don't necessarily, and it sounds horrible, but they don't necessarily have the respect that we deserve and that they deserve. So we have to enlighten them a little bit. Again, obviously something goes into the mouth, it goes down the throat. That's all part of the package. Dental neglect is a difficult term to discuss. And there are parents that are guilty of it here in the United States and around the world. It depends on your culture, but there are parents here that know the child has a problem and still don't do anything. It's failure for a parent or a guardian, whether it's a grandparent or a cousin or whatever, whoever's taking care of the baby, to do the best they can for that child and not neglect them. So we see, oftentimes we'll see a 4-year-old come into our office and they've never been to the dentist. They have major decay. We may have to do 10 extractions. That's neglect on a parent's part. Now they have to understand that that's neglect. Again, cultural aspects say, oh, well, it's just natural. That's the way I was. That's the way my kids are going to be. That's the way my parents were going to be, but that's not correct. Everybody knows that there is prevention. And I don't want to take a 4-year-old kid, and I don't want to do IV sedation or put them in the hospital to take care of it. It's traumatic to begin with. And it's a lot of work for us that doesn't need to be done. So again, neglect is a very difficult problem to take care of. In the United States, there are processes that we have that you can do something about neglect, where you can report them to the government, and they can do something about that. There's foster care, and there's other if they find that the parent is sort of unfit. That's very difficult to do. But the worst thing is that dental neglect leads to, obviously, pain, infections, and major crises. So that's something that really have to work on. Failure to get that proper dental care obviously can result from lack of money, which is fine. That's why there are free clinics here. And I assume that you guys have clinics and dental schools that will have students that will work on them. There are doctors who will, like me or Ibrahim or anybody else, that will say, hey, I will do that child for free. There are hospitals that say, hey, we will do that child for free in the OR because he's got such major problems. There is parental ignorance, which is all over. People just don't know. And again, if they weren't educated, they're not gonna know. If you don't know, you can't blame somebody. So we have to find a way. All of us have to find a way that will sit there and say, hey, what are we going to do to really train and educate these people? And if people just say it's a lack perceive of value of the oral health. They don't think that they're just teeth. That's all they are. And their grandparents don't have any teeth. They don't have any dentures, and they eat and they function and they laugh and they smile and they have fun with the grandchildren or whatever. It's not a perceived value. That's our problem. We haven't made it important enough. And we haven't worked with the physicians to make it important enough. And the physicians are too preoccupied doing some other things. So this was just one state. This is California, and that's what they were talking about. But all the states in any country that I go to, varying degrees. I spoke in Dubai and Austria last year, and they all fall into some variation of what we do. And your problem is no more unique than our problem, then is no more unique than Dubai's problem, and no more unique than Austria's problem. They all have different degrees of those problems. Austria came back and said the same thing. We can't get the parents to come. We don't have the education. The government won't spend the money for it. And we do a lot of sort of patch up and move forward and take it from there. So it becomes substantially more difficult. So again, we have to try to educate. And again, there are issues that arise that we can take care of. Here, this was in the United States, and they've done this in other places, that a mother was arrested for neglect for failing to care for her child's dental needs. That takes it way to the other side. But that's how important the United States sees it, and some other countries see it. You know, whether they did something, what they did in this particular case is take the child away and put the child in foster care. You know, and the little quote here at the end says, a lot of people think that it's leaving children unattended and not providing supervision is really neglect. And that all falls into that. Dental neglect cannot go unattended, because we're going to have major problems. You know, so the issues, again, in your country, I'm not that aware of, but I'd have to sit down and work with you guys in the school and the program to say, hey, what can we do together to help promote better care for our patients and for our neighborhoods and for our schools and for our kids. You know, again, you have possibilities, but I don't know exactly how those things work. Maltreatment can take, you know, form. There are kids that are beaten. There are kids that are you know, locked up in the rooms. It doesn't happen that often, but it happens enough where you have all kinds of problems. And dental neglect is a maltreatment, and that creates a problem for many kids, and they're all victims of maltreatment. If we look at this, maltreatment can fall into the category of neglect, which is the highest percentage. Physical abuse, where kids are beaten or hit or locked up, is 20% of the time. That's here in the United States. It is higher in other countries. Sexual abuse is a major problem, but that's you know, maltreatment. Medical neglect is, you know, sometimes kids don't go, they could have a broken hand and they don't get to the doctor for weeks because the parents thought it was nothing, or they didn't take care of it. So this gives us some idea of where that neglect comes from, and what our issues are. And again, this goes around the world. The numbers may change a little bit, but the issues are still the same. We have a dental disability, which is dental caries and periodontals and trauma and oral conditions that are left untreated can affect the child's development and individual participation in life. The bottom line, again, like I said before, you have a 6-year-old who's in first grade who has a lot of decay and just doesn't feel well, and you don't know why, and the teacher doesn't know why he's not listening and whatever. No one ever thinks that it's the mouth. He's got 4 abscesses in his mouth, and he can't chew, and he can't eat the right foods. He can only stay on soft diets. He can't eat fruits or whatever it is, and that issue becomes a major issue. So if you can't go to school and be healthy, you can't learn. Now, whether it's healthy in your body or healthy in your mouth, you just don't have the ability to learn. After 20 minutes, the kid tunes you out. Oh, my stomach is hurting me, my teeth bother me, I can't concentrate. If I can't concentrate, I can't listen to the teacher, and I can't get an education. And it doesn't make a difference what your financial background is. You know, you could become exceptionally wealthy and still have that same issue, or poor. That transcends. It doesn't make a difference. But if your child goes to school not feeling well, he can't learn very much that day. It doesn't make a difference what he feels, whether it's his mouth or whatever, but they just don't think about it. And I don't know how your programs in school work, but they usually don't send them to the school nurse unless the kid is really like collapsed or sort of bad. And at that particular point, say, hey, I'll send them to the school nurse. Do your schools have nurses? You know, every school in the United States has a school nurse, so that there are, someone that they can go to that can at least create, call a parent or send the kid to a doctor if there's a problem or a major accident. An individual should be considered to have dental disability or infection if they can't eat, which obviously takes intake of food, gives you the necessary energy and helps with promote growth and development. It will delay your growth and development. It'll inhibit your growth and development. You have that kid that comes out and now you take him to the OR, he has 12 teeth that are taken out. Now, how's he going to eat? His diet is going to change. And if his diet changes dramatically, what do we do? How are we going to take care of that? It inhibits his life or the child's life activities. Can he go out and play? Can he play with his friends? Can he, celebrate a birthday party? He can't eat a birthday cake because it's too sugary, it's too sweet, and it hurts his mouth. It affects all kinds of life. You don't feel well, you're not going out to eat with your parents. You guys don't feel well, you're not going out. No, I don't feel well tonight, so I stay home. Well, what happens is then the child continues to stay home, and the parents, either don't pay attention to it or create a problem, or there's a problem that needs resolution. So here we're talking about the impact of dental decay in the United States. Just the United States alone, children will miss 51 million hours of school each year due to dental issues. That's a lot of time. We have a lot of kids, but that's a lot of time. School absences as early as first grade are associated with higher dropout rates. So obviously, if a kid can't have fun at school or is uncomfortable at school early on, that just tunes them out to learning further on. And if you don't feel well and you didn't learn the stuff in first grade, when you get to second grade, you're behind. When you get to third grade, you're further behind. And what happens is you keep getting further and further behind. And as you get further and further behind, by the time you get to sixth grade, you drop out of school and you have no, potentially no future. The effect of dental pain on distraction of school's performance is significant. Teachers aren't aware of that. They don't really pay attention to it because they themselves may not pay attention to it. They may have bad teeth problems. Again, going to the schools and having our students go to the schools or having doctors go to the schools is great because the teacher learns as well as the child. And maybe the teacher stands there and prints out stuff and says, oh, okay, that's pretty good. Now, say, hey, hold on, Mom, I just need to have a drink to settle my nerves before I go to the dentist, because everybody is nervous and everybody picks up on what a parent says, or how many times do you hear when a child goes to the dentist, he's only going to give you a shot, it's not going to hurt. Well, the child never thought it was going to hurt before. And a pediatric dentist compared to a general dentist is different because our offices are set up and the private clinics are set up. The clinics in schools, at least in the United States and in most countries, there is a pediatric clinic in one section. There is a periodontal clinic in another section. There's an endodontic section in another section. And each, that pediatric clinic is set up for kids. So if you're going to do children in your office, which is great, then have a little section that a kid will feel comfortable with, or have a room where you can sort of decorate it a little bit with bright colors or things that a child may like, because that will make them at least a little less fearful. And at the beginning, sometimes we have kids come to our office 2 or 3 times before we actually do something, because I got to get them to feel comfortable, especially if they haven't started early on. Medical necessary care is essential in the diagnosis and prevention and treatment services, including basically, appliances and devices. If you can do that, space maintainers, habit breakers are the 2 major concerns that we have. I don't want that child that just had 18 teeth removed not have anything there to maintain his space for the permanent teeth to come in. Losing anterior teeth in the front, at the beginning, early on, can create speech problems. So sometimes we make pediatric dental partials. There are programs and things that you do. And sometimes you can't do that because you can't afford to do that, but you certainly can plan ahead on treatment planning. And treatment planning is very difficult when finances come in. Again, there are free clinics. Schools are happy to have here, and in a lot of countries are happy to have, because they don't have, you probably have a little bit more than we have, but you don't have a lot of kids that have certain problems. And when we get to the school, that's where they go. When I taught at a hospital back in New York, we were the center for, it was a children's hospital, and we were the center for every major disease. So we could see every child that came in with diseases that you never heard before, you never saw before, and they had all kinds of clinics, but it was geared for those kids. So medical necessity is really reasonable And we're there to create, and I want to monitor that growth and development, and I want to promote optimal health. And again, that's a hard road to go, but you have to take in consideration the patient's age, the development status, the social aspect of feeling better, and setting up the appropriate needs for the family. Because the kid has the problem, and again, the parents may still have that same problem. So they may not get that fixed. And most people, if you have X amount of dollars to spend, will take care of their kids before they take care of themselves. But if I educate the parent, they understand that they need to take care of the children as well. And if that makes sense, then you're doing your job. Medical necessity is basically moving us further if we need supportive services. You know, are we going to do sedation? Are you going to use liquid sedation with medications, general anesthesia, or in an office or out of an office, or utilization of the hospital? Sedation, even from nitrous oxide, which is simple stuff to use, most people don't have it. And that's a great, way to take care of that. If you have an opportunity to learn how to use nitrous oxide, it is a great tool that you can have that is will help relax, whether it's an adult or a child. Liquid sedation, you need to be trained for. So people that are trying to give people Valium or Demerol or Phenergan or other medications that are out there have to follow proper procedures. And if you don't have that proper procedure in the United States, if you don't have a sedation license, you shouldn't be doing that. You should be referring that out. And then the pediatric dentist or the general dentist that does that will then determine whether or not we can sedate in the office. And then people make up cocktails, and they'll put 2 or 3 medications in there. And every time you do that is a health risk. Every time you put a child to sleep, or every time you put an adult to sleep. My father is 95. If he needs surgery, every time he would go to surgery at 95, you don't want to use general anesthesia, because coming out of general anesthesia changes you. You don't want to sedate a child in the hospital unless you have to. And if you have 18 out of 20 teeth that have a problem, then you have a problem. Then you have a problem, and you don't have much of a choice. You have to do that. But there are people that are geared specially for that. Don't take the risk of using liquid sedation, because people will mix 2 or 3 medications and they don't know what they're doing. And unless they're monitoring their blood pressure, have a pulse oximeter to check their oxygen, and have a capnograph for breathing, you can get into major problems. In our office and in most offices in the United States, we try to avoid liquid sedations unless we need to, and then we limit it to 1 or 2 medications. But we do have people come in and do IV sedations, where they can use propofol, where the anesthesiologist will come into my office and monitor and control. If you're going to sedate and you want to sedate in an office, then it's advisable that you get somebody in to support that. Let that anesthesiologist take care of you. That's a private clinic session and setting. In the schools, we had IV sedations where the oral surgeons would come in and do the IV sedations for us, and we would take care of the children. You need to keep accurate records. You need to, no one wants a fatality, but sometimes it happens. Sometimes you're going to get kids that will have adverse reactions. So you need to do special training and have experience in doing that. Nitrous oxide is a different story. It's safe, effective, easy to use. It will sedate and it will take care of those problems, and it relaxes the child. I'm sure you have nitrous oxide in your clinics, or some people will deal with nitrous oxide. It's great for adults, nervous patients, kids. It's a little nose, and what we do is we will take a flavor of a chocolate flavor, a strawberry flavor, a vanilla flavor, peanut butter flavor. We can mix it into the nose, and the kids will breathe into that. And again, it relaxes them, and we monitor and we control the oxygen levels. We don't want to go into deep sedation. It's only there to help. It's not there to put a child to sleep. It's just there to relax them. But basically, all of that stuff are ways to help in therapeutic and preventative ways. Dental care is medically necessary to prevent and eliminate all kinds of diseases, facial pains, and whatever. Obviously, if you get a swelling, especially on the lower, you can use the fascial spaces, and that infection from here, from the lower posterior, can go in a fascial space up into the brain, and you can get a brain infection and die. Fortunately, it doesn't happen that often. Know your antibiotics, know your usages, know when and what to do, and when to send that patient to a hospital or a clinic setting or the pediatric dentist. You want to go back and restore those teeth back to natural form and function so that the child can chew, be out of pain, and take care of that. And you want to try to correct disfiguration and dysfunction. Class 3, Class 2, Division 2, FAR, anterior overbites. They have the same issues that other people have. If you look at, I use him as an example, Freddie Mercury and Queen, he had such a large overbite that he couldn't really, chew properly. That was a problem his parents had neglected because they were comfortable enough to take care of that, but it wasn't important to them. But that's a problem that really sits and resonates with a lot of parents. What do you do? If you can't afford to do that, we have to try to do the best we can to make you functional and work the best we can. That's a process that needs to be, addressed. And that's why prevention, early on care, and the ease of getting in and having a parent more comfortable will be able to get us going on that. I don't know where we are with time-wise, guys, but if you need to stop for a little bit, or you want to stop for a little bit and ask some questions, it's been about an hour. You just let me know, but I'll keep going if you want me to keep going. So what we need to do, or what we try to do, is basically start with community programs, like I had said from before, community programs that will help address these issues. So what we need to do is create those programs. If your school doesn't have a program, create one. It's not that complicated. There are programs that are out there that are easy to use, that are already set up for you. School-based programs, if you guys were to look at, again, toothpaste companies that obviously are there to make a profit, but contact Crest or Colgate or whatever local major toothpaste that you go into the store and they buy, all have dental health month programs that they will give you and let you set up, and then you can go out into the community. That we need to do that. We all need to do that, because if we don't go out to the community and we don't carry the message, no one else is carrying the message. So I want to educate the students. I want to educate the teachers. I want to educate the nurses. I know that it's repetitive, that what I keep saying is the same thing, but it's so important that we continue to do that, because if we don't, we're just digging a deeper hole for ourselves. Again, we need to establish as the American Academy of Pediatrics, and that's the American Academy of Pediatric Dentistry and Pediatric Medicine are the two primary worldwide resources for you all to take a look at. You can go online, you can get all the information that you need, but they have those programs, they have the setups, they have all of the information that you need to get those programs going. There should be no reason that you can't increase by 10 or 20 or 30%. You got to go in little baby steps. If you can get a 10% increase, that's amazing. You'll work on it, but the more you work on it, the more you will get. And again, it's an enriching and it's a fun experience for dental students to go out to a school. We educate our dental students how to talk to kids and how to talk to parents, and how in English to sort of bring it down to a second grade level to make it easier for them to understand and have some fun. You know, we have books that we use. There is a book by an author whose name is Ted Kroll, Croll. It's called The Totally Gross and Disgusting Dental Book. And it's a picture book that has pictures of abscesses, arrested decay, disclosing solution. And we use that stuff to take and show elementary school kids. We also wear gloves of different colors. So we'll take out, when we go to schools and we give tours, we'll take gloves, we'll take the saliva ejector, we'll take, you get some samples of prophy angles that come in designs for animals. Everything needs to be fun, and it should be fun, and you should have a good time. And then what you do is if the school or the clinic has a program, you take pictures of that, and you take pictures of these kids smiling, and you start posting them on the school's programs and the school's websites. So parents will say, hey, look at that, these kids are having fun. I want my kid to either go there, or I want my kid to get something out of that from a school program. That's easy to do. I can help anybody set that program up, whether it's through a school or through a private fee-for-service clinic or private clinic or whatever. The healthcare providers need to diagnose the disease so that we can provide at least the proper care. So someone needs to look at those kids before we get to them. And again, that is all comes part of the education. So immediate intervention is necessary so we can prevent further decay from going on. Now, sometimes obviously you can't, and we can talk about it in a little bit. We can use processes like silver diamine fluoride, which has been around. And it's funny because everything that's old is new again. Silver diamine fluoride has been around since 500 AD, you know, and 100 years ago, it's silver nitrate. They've been using that in dental care for years. And now it's stopped because people came back and said, hey, it wasn't a process. We have better ways to handle things now. But now you have 40% of your population with decay, and you can't even get to all 40% at the same time. So what are you going to do? What are your practices to get in there and help at least arrest or slow down the decay process so you can take care of all those people? So evaluation early on, again, by the pediatrician, by us, by cleft lip and palate teams, by oral surgeons. That's why you have schools. That's why you have clinics, and people need to know that that's the place to go. And again, your website for your clinics, for your schools need to be informative, and they need to show that your place is a place that they want to go to, that is a fun place, that we're concerned about all of this stuff, and that we really want to take care of the patient, the whole family kind of concept. The dentist providing the oral care for the patient has to determine, you know, what the justification is for treating or not treating. You know, do we extract? Do we not extract? When do we extract? When do we not extract? You know, I used to be heroic years ago. I stopped being heroic. Heroic doesn't save us anymore. You can be heroic and try all you want to save as many teeth. And you got out of school and everybody is gung-ho. I want to save the world and I want to save teeth. You just can't necessarily do that. And you have to put into concept and think, if I save that tooth, what is the prognosis of that? If it's fair or less, I'm not going to save that tooth because I may never see that kid again. And I don't want to create more problems than when I started. We've done IV sedation cases, or we've done hospital cases where we say, okay, we're here, we're going to crown everything because we know that will keep us stable. You can do that sometimes, but if the tooth has a 50-50 chance of survival, I'm not necessarily today, depending on the education of a parent and their concern of trying to save that tooth. It's just not worth it. As sad as that sounds, it's not worth it. I don't want that kid coming back 6 months later or 4 months later with another sedation. I don't want to have to sedate a kid 5 times. You know, again, every time you would sedate a child, it's a risk. When they wake him up, is he the same as he was before? I don't know what the anesthesia does with the halothane or whatever else you're using, the propofol. I don't know how that's affecting the brain. but I don't want to do it 5 times. So, you know, we used to restore all the anterior teeth. We don't do that anymore. You know, some people will, and some people will post all their cases online, and they will look phenomenal, and you will say, that's amazing. It's for every 1 good case, you probably have 5 bad cases. It's like people who go to Las Vegas, which is the gambling capital of the world. People go to Las Vegas all the time, and all my friends say they go and they win. They always win. And I say, well, if you always win, why don't you give up your day job? Don't be a doctor anymore. Don't be a lawyer anymore. Don't be a teacher anymore. Just go to Las Vegas and keep making your money. But they forget to tell you all the times that they lose. So they may have won a lot on Monday, but Tuesday, Wednesday, Thursday, and Friday, they lost all that they won and gave it back. But they don't tell you about that. So it's the same thing. A lot of these posts, and I'm not saying anything's bad about anybody. I don't know anybody's practices. I know what I do and how I do it. But a lot of people will show you all their positives and never show you their negatives. And you know what? There's more negatives than there are positives. So you have to be careful. But again, there's another tool like silver diamine fluoride. Again, we'll go into that in a little bit. But silver diamine fluoride that will postpone the decay, slow things down. That's good for primary dentition. It's good for mixed dentition, and it's good for even seniors that can't get care. But we're trying to avoid, basically, we're trying to avoid general anesthesia at all costs. And again, that comes from education. We'll talk about fluoride supplement. Whenever you guys want to stop, I'll keep going. I have no problem. Keep going.
Keep going. We are very interested in such your topics you are passing on. You are mentioning special issues like neglecting and something medical assisting. I would like if you try to continue, and maybe we can delay the discussion to the end of all the course. You fair?
I'm fine. I'm fine. Yeah. I once you start talking, I don't stop.
Continue.
If I go too fast, please
tell
me.
Everything is okay, and your clarification is understandable. People are mentioning and students mentioning on the WhatsApp that everything is okay. We are all appreciating what you do, Professor. You can continue, and very thanks. You can continue. Go ahead.
Okay, perfect. And I know that I sound repetitive. And
everything is okay, and everything is here.
I'm just trying to get across all those points. So now we'll go into fluoride supplementation, and in the United States and in other countries, some countries have fluoride in the water. Some countries don't have fluoride in the water. I live in Arizona, where they have fluoride in the water, but no one drinks the water because the water is so bad. It tastes horrible. So everybody, like me, drinks bottled water. Well, in the bottled water, there's no fluoride. So we all know that fluoride will help reduce the chances of decay dramatically. They have done studies that say fluoride supplementation, if you can put on fluoride varnish, we'll get to the varnish in a second, but if you can put on fluoride varnish 4 times before the age of 2, that will reduce the chances of decay by 35%. That in English, that's a hell of a lot. You know, that's a simple process to do. It doesn't cost a lot, and the pediatrician can do that, or the dental clinics should be doing that. But putting it on, that doesn't mean that at age 6 months, a year and a half, and 2, that they have teeth. They may not get teeth until a year and a half. But as soon as they get their first 2 teeth, you start to put fluoride varnish on, and then you do that every 6 months. But there are ways of getting fluoride into the body. You can get fluoride pills, which are chewable. There are vitamins here in the United States, depending on where you live. When I lived in New York, there was no fluoride in the water. So we took a supplement called polyviflor, which meant that it had multiple vitamins and a fluoride supplement together. If you were opposed to fluoride, because some people didn't want to have fluoride, because they didn't believe that it worked, or they believed that it created major problems in life later on, like fluorosis and brittle bone disease and things like that. You could just do a vitamin, or you could do a fluoride chewable pill, which was the size of a pin. They had little grape chewable pills that you start. The recommendations start at 6 months, and they follow through until the age of 13. I stop somewhere between 10 and 13 when the 12-year molars are in. I stop giving the fluoride. You have lozenges, which you can suck on, or you can have little drops. They also sell fluoride water. You can in the stores. Now, I don't know in Syria, but in the United States, there's what's called nursery water, which they sell. It's a water, regular water. It's basically, again, my bottle of water that has fluoride in it. It will say it in the store. So there are 4 or 5 different ways that you can get fluoride in. But statistically, the fluoride will help reduce chances dramatically. Again, there's 4 fluoride applications before the age of 2, 35%. That's amazing. The evidence supports it. The studies have shown it. The effectiveness for primary teeth is great. Obviously, you know that the day the baby pops out, those teeth are forming. That if you look at a cross section on in your anatomy book of a skull, you're going to see the primary teeth coming in and the permanent teeth underneath growing and developing. And I explain it to parents that every day we take a new layer. Every day we take that fluoride, there's a new layer of tooth being built on each other layers. And every day that new layer that has the fluoride is stronger. It's like building a house with Legos. But if one of the Legos is rotten, then you're going to have a problem, and it's going to collapse. So you want to do that. There's a town in Montana, in one of the states in the United States, Montana, that has naturally occurring fluoride to excess. And that means in their drinking water, there's too much fluoride. They've done studies that have shown that the fluoride there, the incidence of decay is virtually 0. The incidence of decay, other issues, other medical problems, heart, lung, liver, bones are negligible, are no different than any other population. So the only issue with that is fluorosis, where the teeth are pitted, brown, stained, and they don't look good, but they don't have any cavities. That comes from the excessive fluoride. If you follow the regulations, and whether you believe them or not, if you follow what you're supposed to do, you're minimizing the amount of fluoride and maximizing the protection. Now, some parents will say, and that's fine, they will keep the 0 to 3-year-old dose. It was 0 to 3, 3 to 6, 6 to 16. So some people will say, and I'll look at a child, my kids were on 0 to 3, and they stayed on that 0 to 3 dose, which is a 0.5 milligram of fluoride, until they were about 13, because they didn't really have very many cavities or decay at all. You have to size up each kid, and you're going to have to size up. Now, whether you get a parent to accept that, if the pediatricians refer and say, I want you on vitamins, in the United States, parents will go buy vitamins. Instead of buying the vitamins, they'll buy the vitamins with the fluoride. I don't know what's happening in Syria. So if kids are on vitamins, you can get the vitamins with the fluoride. It's the same thing. It may cost a tiny bit more, but it's the same thing. And the pediatrician will decide what it is or how you're going to get it. If you don't do that, the supplements work phenomenally well. You can use a fluoride rinse like ACT or FluoroGuard, but in all reality, and there's stronger fluoride rinses, there's stronger fluoride toothpastes. In reality, if you don't use those over-the-counter fluoride rinses on a daily basis, they don't work. If you're going to do it Monday and then the next day you do it as Friday, it's not working. It's just, they're not effective. You can use a heavier duty fluoride toothpaste, which we recommend to kids when we do our caries risk assessment. Kids with higher caries rates, we will ask to get prescription toothpaste like Prevalence 5000, which has more fluoride in it than the average toothpaste. If you can't get them to have toothpaste, the fluoride supplements, we're supposed to use a tiny bit of fluoride. When you're taking a toothbrush, it should be as thin as this paper, where you smear it on the toothbrush and you brush the child's teeth. I would say if you're not going to get fluoride supplements and you're not going to get fluoride varnish, then you might want to use a little bit more if they're using toothpaste, you don't have to use a baby toothpaste. You use an adult toothpaste that tastes good, a kid's toothpaste that has fluoride in it. Just use a little bit more because they will swallow it and they will get the fluoride that way. So there's different ways to get there. I'm not really worried about moderate dental fluorosis. You'll see a lot of that in the United States. It's a whitish line. It's there. I'm willing to take that, which is a cosmetic fixable problem, instead of having 20 cavities. So I will take that. Now, fluoride varnish, it used to be where people will put things in trays and you put it in for 4 minutes, and that fluoride that you used in school doesn't really work because the kids didn't sit there with the trays for a long period of time and they just didn't want to do it. Fluoride varnish is easy to use. It comes in basically a little tube like this. You squeeze some out. The cost in the United States to do a fluoride varnish is 60 cents. I don't know what that is in Syria, but you can get 3 or 4 applications using a different brush for a kid. You take a little bit out, you put it on your glove, you dry the teeth off, and you paint it on the teeth. And it sits there, and then the kids go home. It's easy to do. A pediatrician can take one of those tubes, one of those little containers, and probably get 3 or 4 usages out of them. Again, take a paintbrush full, put it on your glove, hold the baby down, put it on the teeth, and go home. That 60 cents now costs 10 or 12 cents. You know, it's a small price to pay. Now, yes, you have to pay for it, but it's a small price to pay. And obviously dental clinics and schools and whatever get reduced fees or costs because they buy a lot. So you can get that fluoride varnish and use that. I will give that to parents with, or have them come back every 3 months when I don't trust them, to put on another fluoride varnish. And that is the easiest thing you can do. If I see little things starting, come back and use the toothpaste, but the fluoride varnish. Fluoride varnish tastes good. Some of it is yellow. They now have white fluoride varnishes. There are plenty of companies that are out there that have great tasting fluoride varnish. It's great for adults. They have sensitivity. You put that fluoride varnish on there or the Prevalence toothpaste on there, and it'll clog up the dental tubules and you reduce your sensitivity. So there are ways to get that fluoride in there. Again, Carrie's assessments will tell us how we do that and where we go with what we use. Again, I don't just trust a parent. Here is the supplementation guide. It's a little old, but it's not that far off. If you're looking birth to 6 months, there's no fluoride supplement. 6 months to 3 years, you're using 0.25 or 1/4 milligram. Depending, if you look at this chart, depending on how much fluoride you have in your water. If you really wanted to check and you don't have fluoride in your water, then it doesn't make a difference. But if you're using well water, sometimes some of the well water will have fluoride in it. You can test it. Most people don't. Most people will go with the first column and just follow through. If you are not sure what they have, you can keep the child on the 6 month to the 3 year dose up to the age of 12 or 13. This goes to 16. I stop when the 12-year molars are in, because chances are when the 3rd molars come in, they've already developed. And if they come in all the way, we should be okay. And if they don't come in, they're going to be extracted anyway, because chances are they're impacted. So I don't worry about it. But when I do the 12 years, when I stop at the 12-year molars, the 12s, then I do that. You can pick and choose, and each child is based on, again, whatever their caries index is. High, I would follow through with all of them. Low, I'd stay on the 6 month to 3 years. Again, that's all standard. I don't know if you guys are doing anything, but if you guys want to take a picture of the screen, or you guys are going to print out something later on, these are all things that are available on the American Academy of Pediatrics, but this is stuff that I have here. You can, if someone wants to take a picture of it, take a picture of it. But this is the standard of care now. And again, it depends on where you lived, depending on what you're going to do. Water fluoridation has been in the United States in some cities since the 1940s. I grew up in Pennsylvania, and I'm old. And in 1954, when I was born, they had put fluoride in the water in Philadelphia. And when we moved to the suburbs, my sister, who was born in 1960, was born in the suburbs. She didn't have fluoride in the water. She had more decay than my brother and myself. So they attribute that mostly to the water. We drank a lot of water. Again, drinking a lot of water, bottled water, doesn't get you the fluoride that you need. But drinking the tap water, if it has fluoride, having 8 ounces of that fluoride water, or 4 to 6 ounces of fluoride water, nursery water, is what you want to get. There are other, if you look at things, and I also do some holistic stuff and natural medicine. If you drink a lot of tea, green tea has naturally occurring fluoride to excess, which is great. There's more fluoride in green tea than there is in any other tea. Teas have fluoride, but green tea has the most. So if you need to do something with tea, because you drink a lot of tea and you need to even sweeten it, you can sweeten it with any natural sweetener, from xylitol to stevia, any natural plant substitute for sugar will make it sweet enough for a child. But if you look, almost 2/3 of the water systems in the US have fluoride in it. And now most countries don't have that because it's obviously an expense that they have to put in. So we have to figure another way to get that in. So I would say, hey, drink green tea. If it's hot where you are, make a jar of big green tea, put it in the refrigerator, throw some ice cubes in there, throw some sweetener in there. You can throw a little bit of honey in there if you want, but honey is anti-inflammatory. If you got a cut, you can put a little honey on it. Go and look up natural remedies. There are tons of natural herbal remedies. And there are tons of natural physicians that are out in the world that are publicizing all of that stuff. On a lot of the posts, I post a lot of stuff on a fair amount of pediatric dental forums, but they're general dental forums that are out there. And anybody that wants to learn some stuff about that, you can do that. I just put on the other day, lavender is a good way to promote calming. You have a child that's nervous, or even for you, you're stressed out, you want to sleep, you can breathe in a little lavender, just or have lavender smell in a candle or whatever, and that will work. So there are different ways and different natural remedies that are out there. So try the green tea if that seems to work. Again, there are certain countries and certain places that are opposed to water fluoridation, and public health companies counties that don't want that. I have no problem with it. You have choices, as long as you pick one of those choices. I believe that having it in the water system is great, but if you're not drinking the water, it doesn't help us at all. So I have to get it in someplace else. Again, most fluoride toothpastes contain about 1 part per million of sodium fluoride or sodium monophosphate fluoride. Prescription strength has 5,000 parts per million instead of 1,000 parts per million. So obviously it's substantially more effective. And that works the same as regular toothpaste, and it's well established. They've done studies that show 1.1 sodium fluoride is safe, effective, and helps prevent decay. So if you have a parent that will at least has a child with a lot of decay and may follow your recommendations, having them take some prescription like Prevalence is a good alternative. Again, if they're not going to do that, I don't want them to take a blob of regular toothpaste. I still want them to use a small amount of toothpaste, but take that small amount of toothpaste and brush it and let the kids swallow it first, and then you can rinse out. But there are different alternatives that are out there that you can use to get that fluoride in. Again, the most common, we talked about mouth rinses from before. I don't particularly like them. If a kid wants to use them and they use them all the time, it works. If they're not going to use them all the time, you throw money away. So for the couple of dollars that they may, if they have the money to spend to buy that, I would rather than spend a little bit more and get the fluoride toothpaste, the Prevalent, than the fluoride rinse. Prescription mouth rinses are obviously substantially more effective, and they are great for kids who will use them. They are great for kids who have basically orthodontic brackets on there, and areas where there's no fluoride in the water. Now, when kids come to my office, we use disclosing solution. Now, I'm not sure that if you guys use disclosing solution or not, but it's the red stain that you take a Q-tip and you paint the red stain on the teeth. And then to use that as an example, you show the child, or even an adult, you show them in a mirror where all the plaque. They put the red stain on, it stains the plaque, and then they rinse out, and everywhere there's a bright red stain shows that there is plaque on the teeth. That's where they're missing when they brush. There's also a product that has two-tone disclosing solution, where it will stain plaque purple and red. The purple means that that plaque has been there longer than 24 hours. The red means it's new plaque. So as a tool, and what we do sometimes in schools, and when we do our little tours, we'll put it on the kids' teeth. We'll have them eat a cracker and then put it on the teeth, and then you can wipe it off. But it shows them, it illustrates them. That book that I talked about, that totally, by Ted Kroll, that totally disgusting, gross book, dental book, has pictures of pre and post stain. And it's a great tool to use to show parents and to show kids. Parents will walk in and say, oh yes, my child is brushing their teeth every day. Okay, great, I believe you. Until I put on the disclosing solution, and all of a sudden I show them the disclosing solution, and there it is. They're stained. They're purple and blue. They haven't brushed their teeth in 2 days. They have been faking you out and basically saying, hey, oh yeah, I've been brushing. You know, children are children. They're no different than we were. How many times did you say to your parents, oh, I brushed my teeth, and then you know, wet the toothbrush? See, it's wet. So there are different ways to show, and that's a good way to show a parent. They can buy this little solution. Again, fluoride gel and foams that we talked about. The foams that we used to use that came out of the little aerosol can that we would put in a tray and let sit there for a minute or 4 minutes is effective, but not nearly as effective as the fluoride varnish today. I mean, the fluoride varnish is the state-of-the-art product to use. You will use gels and foams and even varnish on patients that are going through, and whether it's an adult or a child that's going through head and neck radiation, which dries the salivary flow, and they can't you know, create enough saliva to wash away the plaque. So they will make custom-made trays to put in cancer patients, whether it's a child or an adult, and they'll put them in there, put the varnish in or put the gel in to help to create a strengthening of the teeth. There's also a toothpaste called Biotene that's out there for dry mouth. There are a lot of people who are on medications like antihistamines for allergies. There's all kinds of allergy medications. Here, our allergies are bad now because all the flowers are blooming. The cactus flowers, the trees, and the air is sending away the pollen. So more kids are on antihistamines, and that will dry the mouth. There are a lot of kids that will have dry mouth or will have sinus infections who are on sinus rinses like Flonase or over-the-counter, sinus medications to help reduce sinus infections or allergies. What happens is, as that goes down to the back of the throat, you kill good and bad bacteria. So your mouth becomes, the saliva flows less, the mouth becomes a plaque trap, plaque gets stickier, you get more stain. So we'll get kids who are on Flonase to come in, if we can, every 3 or 4 months to have their teeth cleaned, because you'll see that they will pick up more. It comes off. It's chromogenic stain. It comes off, but because the plaque has changed, the bacteria in your mouth has changed because of the Flonase, it just makes plaque stickier. You'll also see a lot of kids when they come in with black iron stain. Here in the United States, we see it a fair amount. There are a lot of babies who are put on formulas with extra iron. And as those teeth erupt, you'll see black stain, chromogenic stain. It comes off. We get that call all the time. My kids' teeth are black stains around. Those kids we have come into the office a lot more frequently than other kids. So basically, you'll see a lot of that stain. Again, the gel and the foam works. We tell everybody not to eat anything for 30 minutes afterwards, but I still prefer Fluoride Varnish. And again, I have some kids who are on 6-month regimens. I have some kids that I have come in every 2 months. I have some kids that I trust the parents, and I say, here are 2 or 3 containers of it. I tell them what to do. I want you at the first of every month to do that, and then I evaluate them every 3 months. You have to do a caries risk assessment on every child. And again, just because one child has a ton of decay doesn't mean the other one does. There's a hereditary predisposition and things like that that's there. So, we talk about gels and foams and fluoride varnishes on teeth that can't be sealed. I've changed my mind. Yes, I love the fact that you can put fluoride varnish on those teeth, but I also like the fact that there are products out there now as teeth erupt. Until you can get a good sealant on there, I now have done a lot more silver diamine fluoride on those teeth as they're erupting to help arrest whatever decay might come up until they come in, and then I can get some sealant. The problem with silver diamine fluoride is that when you use it, and it's not expensive to use, it's 60 cents a dose, and you can get 4 to 6 teeth out of that, but that will arrest the decay. It also turns the decay black. So you may see a lot of children who come into the office with black inactive decay. It's arrested decay. Do you have to restore that? No, don't touch it. There are people, you'll see posts of people who have taken all those arrested decayed areas, and now the pre-op is arrested decay, and then the post-op is all crowns. The decay is arrested. It's not going anywhere. There's no reason to put on crowns. That's a kid that was sedated for no reason, in my opinion. Now, again, I haven't seen the kid, but I've seen plenty of cases. So I will put that silver diamine fluoride on a child that comes in with active decay. I will also put silver diamine fluoride. You'll scoop out the decay. You don't need to anesthetize. All you need to do is isolate a little bit. You can do it on a lap. You can do knee to knee. You can hold that child down, hold it in, paint it on, and do one application. And then get them back the next week and do another application. We usually do it in 2 or 3 applications, and it'll arrest the decay and stop. It's great for kids that come in, and in the United States, if you look at the hospital admissions or the hospital cases that get done, people are waiting here sometimes 3, 4, 5, 6 months to get an OR date to have that done. If I can put on that silver diamine fluoride and arrest the decay, I can either postpone the work, or I can eliminate all the necessary OR cases to begin with. You know, you have to size up every case. Again, it will stain the teeth black. So if you make the parents aware, if you're putting it on the anterior teeth, I have a whole full day lecture on that. If you guys ever want to do that, I have a whole full day, 4 or 5 hours on silver diamine fluoride. But you put it on the teeth, and if the teeth look bad to begin with, if they look black, they're not going to look any worse. It will arrest the decay, and that's a way for somebody that can't afford to get treatment done. It's also great for adults. You get somebody in a nursing home, or somebody who comes into your office who's 50 years old, who has a ton of decay and can't afford to get any work done. You certainly can put on the fluoride varnish and also the silver diamine fluoride to arrest that decay until they can get it back to the clinic and take care of that. So, again, you have to pick and choose, but I'd stay away from gels and foams, and I'd go strictly to a fluoride varnish. Again, the practical advantages of that is that it's easy to apply. It has a good taste. There is a company out there, it's called Wonderful, WONDERFUL, Wonderful Fluoride. I know the guy that makes it. The fluoride uptake from the varnish is great, and the fluoride tastes delicious. Kids like it. So you don't have a problem where the taste is nasty and you can't get a cooperative kid doing that. It says here that there's no published evidence yet that indicates that professionally applied fluoride varnish is a risk factor to enamel fluorosis. There's nothing that I've seen that will promote that, and I wouldn't care. If it gave a little fluorosis somewhere, I'm still preventing decay. It's easy to brush. It's a throwaway bend the brush. It takes a couple of seconds to do. And again, even on a 1-year-old, putting it on the 2 teeth, you dry it, you put it on take a 2x2 gauze pad, dry it off, paint it on, the kid's done. I mean, it's that simple stuff. Indications for fluoride therapy for the varnish and or silver diamine fluoride are white spots. You see all those children with hypomineralization from orthodontic treatment or just beginning before they get there. If I see a kid that has those white spots starting and those lesions are starting, I put them on heavier duty fluoride toothpaste and fluoride varnish every 3 months. Active decay, you can put the fluoride varnish on and it'll slow it down. Again, silver diamine works better. Orthodontic treatment. Unfortunately, most kids who have braces don't brush their teeth. They eat the foods that they're not supposed to eat. And if you use the disclosing solution like we use on everybody else, they actually see what it looks like, and they have a better idea. And you have to put it on terms that they understand. You say, do you want to go out and have your friends see all that junk on your teeth? You don't want to see a cute girl that's over there, or a cute guy over there with bad teeth. So you want to take care of your teeth. You have to bring it down to their level and to put it on terms that they understand, so that it makes more sense to them. It also reduces the sensitivity. Fluoride varnish, when you get erosion, or people will take the death grip, as I say, on the toothbrush. They take that toothbrush and they grab it so hard and they brush so hard, and they use hard bristles, and they wear away the gingiva, and you expose the cementum. And as you expose the cementum, you get more sensitivity. So we have toothpaste like Sensodyne. I like the fluoride varnish, or even the silver diamine fluoride, which was originally used for reduction of sensitivity, is great. It's good for institutionalized patients that can't get out and can't get to the dentist because they're stuck. And it's also good for decreased salivary flow. So all the stuff ties in together, one step at a time. How do you tune out the noise? Here's a kid that just says, oh, this kid is going to scream and cry and do whatever. So if we go back and we look at the teeth, He's got the 4 lower anterior teeth and the 2 primary first molars. So this kid is obviously probably 2, give or take. If this child had had the fluoride varnish, again, that would reduce the chances of decay by 35%. If they're going to make noise, they're going to make noise. Bottom line is, in English, it's too bad. You know, sometimes you have to do what you have to do. I put my child, my little one, to bed when she was younger, and she didn't want to go to bed. So she would kick and scream or whatever. That was her time. You know, they have to get up in the morning and they have to go to school, or they have to do this, or they have to go to the doctor because they have to get a vaccine, or there's certain things that they just have to do. This is one of those things. But if you start early, this noise is limited. You're going to get, baby will cry at a year and a half, 2, 2.5, maybe even 3 cry if they've been coming. But by the time they get to 3.5 and 4, they run into the office because they're going to get a sticker. They're going to get a prize. They're going to get their teeth cleaned. And you don't have to do everything at one time. It's not, you know, bottom line is you want to do a prophy, but statistics and studies show that if you wipe away the plaque, you're just as effective. If you brush your teeth with a toothbrush and wipe away, that's just effective. If I can use a prophy angle, that's great. But to get stain off and remove that, but you don't necessarily have to do that. So you tune out the noise. I turn the radio up, I tune out the noise, and that's just the process of working with kids. You know, there are issues in the United States for failure to refer, which is probably doesn't happen in your country, but there are doctors who need to take responsibility because that's part of their medical oath, is they're there to take care of the child. And it's not just the medical issues of the child, it's the whole child. And the whole child means the teeth. That's part of it. It's their responsibility. If I can't get to them and say, hey, you got to get to the dental home because I haven't educated them, then I expect them to do that. And failure to refer is a major problem. People believe that it's unethical for a dentist to ignore the disease or condition. And dentists do the same thing. You know, it's unethical for a dentist basically who keeps saying, oh, come back, we'll see him. We don't need to see him till he's 3. That's unethical. You know, if you don't want to do the child, that's okay. Don't do the child, but then refer them to somebody who will do it. If you don't like the screaming, listen, I don't like to do root canals. I know Anas likes that, so that's perfect. I'm sending him to Anas because he likes to do the root canals and he's going to do the root canals. I could do them. It takes me too long. And I want my patient to get the best care, and I want it to get the best care in the shortest amount of time. And if it's appropriate for my kid to be referred out, then I will refer them out. Here, they're worried about losing a patient or losing parents. You know what? They don't. But the bottom line is, it doesn't make a difference. You need to do that regardless. It's just, you need to refer out. So if it's beyond your scope, I'm not wiring a jaw because it's beyond my scope of treatment. When someone comes in with a fracture, I will refer out. This can be, you know, risk management says it can be expensive. Yes, and it can, depending on what techniques you use. After a while, you know in 2 seconds what their risk factors are. You can document it. There are forms that you can fill out that will talk about risk factors and prevention-oriented things. But any pediatric dentist can look at it in 5 minutes and know that this kid has a high rate, low rate, and whatever. But you need to assess that child, and you need to take a good health history, and you need to get a good family history. So before they even get anything done in the chair, you need to talk to the parents. Now you can look at a parent, if they don't have any teeth, you know that home care is not an essential. So that moves them up along the line and carries risk assessments. Failure to recognize the problem is a major issue. And again, that goes back to us, and it goes back to the pediatricians. You know, there are pediatricians that again, just look straight back at the throat and never say. We get patients all the time and say, some are telling the truth and some aren't. But they'll say, well, my doctor never said anything. That decay has been there for months. You have arrested decay. That decay has been there for months and months and months. And you've been to that doctor many times, and that doctor has failed to do stuff. That's not being responsible to the patients. Now we have to educate them, and that's part of the problem. Failure to come to the office is a different story, but the doctor says needs to go and say, hey, you need to go. There are too many people in the United States that will sue people for not taking care of it properly, and this happens to be one of those issues. There's been doctors that have been sued for failure to refer to the dentist and have that in their notes. In the United States, you should keep good notes no matter what. You need to put down what you used, how much you used, what we did in school, was all of that stuff. And then all of a sudden you get out of school and you don't do that anymore. It's like using the rubber dam. Pediatric dentists use the rubber dam all the time. Most general dentists don't use the rubber dam because they just don't like using it, and they don't want to clamp the tooth, and they don't want to do that stuff. But we were all trained in those techniques. So we were all set and taught that stuff, but we need to follow through with it. You need to recognize. So the failure to refer is a problem. You're setting up that child for the rest of his life by saying, don't come in until 3. And now they come into me, and now they're traumatized, and now I have to put them in sedation, and now I have to do all kinds of other things. So from the law standpoint, you need to refer. Again, that may be just particular to us, but that's the appropriate and the right thing to do. At home routines, here's this little kid that's saying, I'm not brushing my teeth. You can't make me do that, but you can. Treating the infant is are you crazy? Is interesting. And when to refer, we've already discussed. When to refer. That's the point. Is that you refer when it's appropriate to refer. When you brush the child's teeth, it's simple stuff. They don't have a choice. All 3 of my kids were different, but my little one was like possessed. She was the devil. She never wanted to brush her teeth, but we put her down on the floor, and it sounds horrible, but we used to pin her down on the floor and brush her teeth. Now, after 2 weeks, she gave up, and she would know that it's time to brush her teeth, and we would do that on the floor or on the bed. I could do that. We stopped after 2 or 3 years because I just wanted to make sure I was doing a good job. But I could have said at age 7 or 8, Sid, get on the floor. I'm going to brush your teeth. And she would have been, okay, let's do it. You brush your teeth in the bathroom, but you don't have to brush your teeth in the bathroom. If the kid's going to swallow a little bit of toothpaste, you can brush in the bedroom. You can brush outside the bathroom. You can brush walking around. I don't like the fact that a little kid will walk around with a regular toothbrush at 2 or 3 because they, at 1 or 2, because they can fall. If they fall while they have the toothbrush in their mouth, it's very possible that can go back into the tonsillar area and it could pierce an artery. It has happened, and it has happened more than a lot. So they do make toothbrushes that are shorter so that a kid can only get back to the 2nd molar and it can't go back any further. And they make like little teething ring toothbrushes that a child can hold on to, and it's a circle and they can brush. There's all different kinds of toothbrushes. And a parent can hold on to the toothbrush. The kid is brushing their teeth because you can use a finger. Kids are brushing the teeth because they like the taste of the toothpaste. They eat the toothpaste, and that's fine because we want the fluoride in there. So the bottom line is, in that particular case, I want them to do that. I need to have them brush. If you're trying to toilet train a baby to go to the bathroom and the bathroom is a problem, then brush their teeth outside of that, because they're going to associate toilet training with bathroom sometimes. Considerations for referring is basically, high risk. I don't want to do it, but your child has high risk and needs special care. This is a good, if you're going to take a picture of something, this is a good picture to take, because this is where you can show a parent or a school or a physician as to what we do and why we do what we do. And if you read the stuff, to refer, you want to go to a specialist because they have a developmental disability. We'll get into that in a little bit, but developmental disabilities or special needs And there's more and more people who are on the autism spectrum. When I was in Dubai in the summer, in the fall, they don't use the word special needs or disability. They use the term people of determination. I happen to like that better because those people are determined and they're there. I don't like disability, which means that you have something wrong with you. I don't like developmental because, you know, that says you are not normal. I don't like autism spectrum or terms like that because that puts you in a group that you don't necessarily belong. We understand people of determination puts all of those people together, and I just think it's a nicer term. People don't want to hear, you know, years ago you used to say your child is retarded, you know, retarded in growth and development and brain function was what it actually meant, but that was not a great term. You use whatever you want to use, but that's when you refer. You have somebody that's there, a Down syndrome kid that you can't handle, then please refer it out. And the sooner we do it, the better off we're going to be. If you're talking about, again, infants and childs with rampant decay, you know, who need sedation and general anesthesia, that's who's going to refer. We're talking about people who are undergoing radiation therapy, chemotherapy. That's beyond the scope of a general dentist in most cases. We should all learn about it. You should all know about it. And you should know, hey, there are plenty of children that are out there that have cancer, unfortunately, and they need some of that treatment. Part of their problem is they are so preoccupied with getting some of that care done that the last thing they think about, and I don't blame them, is the mouth. So you'll see cancer kids come in with bombed out mouths and tons of decay because the parents, you know, they got to get the kid to eat and they've got to give them milkshakes and they got to give them lollipops or they got to do this and they got to do that because they can't get them through the chemotherapy treatments. So your heart goes out to them, but that's what happens, and it really becomes a problem. But I understand that, and you say, hey, Mom, we really have to work on this together. I will also put some kids on Paradex, kids with rampant decay who are young. And besides using the silver diamine fluoride, we'll use Paradex or something along PerioGuard, along, you know, chlorhexidine rinses, where I'll take it to put it on a gauze pad. And they've done this in Mexico for years, where you put it on a little gauze pad and you just wipe the child 2 times a day, in the morning and at night, and that changes the bacteria in the mouth. Don't make it sopping wet and don't let them eat afterwards because it has a bad aftertaste. But that will work. You want to refer to anybody, to a pediatric dentist when there's facial swellings or something that you don't know anything about. Don't take a chance and say, hey, this is what it is. Thumb sucking or pacifier habits. You know, I put it in perspective. If the kid is relatively normal and they want to suck their thumb or suck a pacifier, so be it. You know, I'd rather them, in the United States, I would rather them have orthodontic treatment for 2 years than psychotherapy for 30 years because they were stressed out because their parents did something to them. You know, if something doesn't look normal and you're taking care of it, refer out. You know, there's a whole bunch, cleft lips and cleft palates. You can do as a general dentist, you can make mouth guards for kids who are heavy duty into soccer or playing sports, whether it's the United States or whatever. People who are dental neglect and abuse, people who suffer dental trauma. If you don't see a lot of dental trauma and you don't know what to do with dental trauma, whether it's a fracture or a subluxation or avulsion or whatever, then refer it out. You know that if the tooth, a primary tooth is avulsed, you can't put it back in. You can, on a permanent tooth, if you have a fracture and they come in with the piece, you can put the piece back on. You can bond the piece back on, even if it's been in the middle of nowhere. I had a kid that came in and they have a swimming pool and the child hit their tooth and they broke their tooth and they lost the chip. So we bonded up. A week later, they came back, said, we found the piece of tooth. We found the piece of tooth in the pool filter. Can you put it back on? We said, all right. We took off the bonding. We put it back on. It lasted about 1.5 years and it came off. and they brought it back again. We put it back on, and it's been that way for 5 years now. So, you know, if you know, as a general practitioner, you want to do that, go ahead. That's great. You just have to study on how to do that. You just need to sit down and say, what are my capabilities? What can I do? What should I do? What shouldn't I do? And then refer. Hold on one sec. Okay. Again, we talked about this before. Here's a cute little kid at 6 months. If you take this baby now and I tell you what to do now, maybe you'll listen to what I said, and I'll give you the information and I'll give you the nutritional stuff, and maybe you'll follow some of that stuff. And maybe I'll see you when the child is a year and has 2 teeth left. Carrie's risk assessments are, again, all different forms. You're going to look at it and create your own. There are all different types of Carrie's risk assessments, and most of it is done in school. And if you have the time in school, it's a great tool because it helps you learn what their risk assessment is and what they can do, or what you should do and how you should go about doing that. As we get out into the real world, whether you're a general practitioner, specialist, or whatever, you can do your own quick risk. But I always put some type of risk assessment, and I grade them A, B, and C, or whatever it is, and I put them in my charts. Here is, you know, another picture opportunity if you want. Carrie's risk assessments from 0 to 3. They're pretty much all the same: high risk, low risk. You know, do they receive the fluoride? Do they not receive the fluoride? Have they gotten the varnish? You know, is the care, sometimes the parent or the caregiver has a low socioeconomic status, so they're not going to spend the money. That moves them up a rank in the risk. Do they have white spots? Do they have visible cavities? Do they have plaque affiliated with it? And then we'll mark it down as high and low. This can go in, this is the 0 to 5. It's the same thing. Are they drinking the fluoride water? You know, are they missing any teeth? You know, you could go on and do strep mutans tests. You could do a lot of stuff. You have a certain amount of time to do, and you have to make that judgment on that. This is Carrie's management. This is a good another picture that you might want to take. You know, low risk for some kids. All 3 of my kids are on different schedules. My little one, who has more decay, hasn't had anything in years, but she goes every 3 months. My big one, who has nothing, goes every 18 months. And my other one, because she has insurance, goes 4 times a year because they pay for it. But she could get away with every year. So you have to, you know, look at all of these interventions, look at the diet, look at the home care, and then make the diagnosis on what their protocol will be. There are, again, everybody is totally different. Same thing on here. You're going to look, this is for older kids, but it's the same thing. Is the parent engaged? What is their diet? Do you have much control over their diet? You have as much control as you want to have in the house. You don't have that much control outside the house, but you can limit it inside the house. And again, if we talk about drinking something, drinking that sweetened green tea is better than drinking 100% orange juice that has a ton of sugar in it, or apple juice. You know, if you never start that process, then the kid never gets used to it. So oftentimes, and different countries will have different styles of bringing up the baby. A lot of people will take sugar water and let the baby start drinking sugar water to reduce colic and all that. That's insane. Baby should only go to bed with either milk, breast milk, and wipe around, or water, and that's it. If they're going to eat chocolate, nothing wrong with that. I like chocolate. I like dark chocolate, and dark chocolate is better than milk chocolate. Dark chocolate, the bioflavonoids and whatever has more cocoa products inhibit decay and plaque more so than milk chocolate. So if you have to have something, that's something. There's always something to substitute something with. You know, you want something a little sweet, you can have fruit and whipped cream. You know, there's different ways to get whatever you need sweet. Whatever your country has in food, if you're making baklava or whatever it is, and you substitute sugar substitute like stevia, For sugar, okay, or you use less honey or whatever. There's just ways to play around with it. That's an education process. This is for older than 6 year, greater than 6. You could do bacterial levels of streptococci. You need to consider the fluoride. There's a lot more considerations, but if you've been doing your job right, they should have a lower carries risk. But if this is a kid that's coming to your office for the first time, you're going to do your own risk assessment. This is just a kid. They're eating. You can get sugar-free pops. These are 3 cute little kids. If that's a sugared ice pop, it's a problem. If it's a sugared sweetener ice pop, no problem. Anticipatory guidance is something that we have to pay attention to. We want to sit there and look at it and say, hey, what are our milestones? Where is the kid? He's 8 years old and he hasn't gotten a tooth yet. It might be a problem. We'll also get people that come in all the time and say he's 3 years old or 2 years old. He hasn't had any teeth. And there are doctors that will take 20 x-rays, which is crazy. If he doesn't have a tooth, he doesn't have a tooth. If everything else is normal and his milestones are fine from a health standpoint, it doesn't make a difference. But you have to do everything individualized and discuss with the parent and with some type of counseling in there. What's appropriate? Someone just posted on one of my posts. He was an 8-year-old kid. Number 8, or the permanent first molar was coming in over the primary. The anterior tooth. Permanent anterior tooth was coming in over the primary, and she was concerned. She thought her child was weird or whatever it is. What should we do? The tooth was loose. We said, just wiggle it out. If the tooth was over retained like it is on the bottom, then sometimes you need to extract. And you got to realize if the 2 bottom front teeth are over retained and there's still half a root or more and the permanent teeth are coming in, I want to extract those teeth. But when I extract those teeth, please realize that the width of the permanent teeth is twice the size of the primary teeth. So I could take out those 2 primary teeth, and those 2 permanent teeth are still going to push the 4 teeth out. Or some people may lose 4 primary teeth and only get the 2 lower anteriors first. The other 2 are there, they'll come in. You sit down and you look at radiographs, because we'll get that in a minute, but you pick and choose your radiographs. But the time to take a Panorex is, some people will take, just for money, will take a Panorex on a 3-year-old, which is criminal in my mind, unless there's something that looks way off. You take a Panorex at age 6, when the 6-year molars come in. You take a Panorex at age 12, when the 12-year molars come in. You take a Panorex around 18, when the 3rd molars are being diagnosed. And if there's any trauma or injuries in between, you take those Panorexes when it's appropriate. Again, you want to sit there for anticipatory guidance. You want to make sure that you want to discuss habits. You want to discuss the finger, the thumb, the pacifier, the chewing of the pencil. Every kid has a habit. You look at 2nd graders taking a test. Everybody has a habit. Someone is biting their lip. Someone is playing with their ears. Someone is twirling their hair. Someone's biting their fingernails. Someone's picking their nose. There's all kinds of habits that are there. You just go over habits with parents. This is another picture. If you're talking about it, is guidance for 6 to 12 months, what you should be looking at, and the tools that are there, and you're providing oral hygiene counseling. You're removing the plaque and the stain. You are assessing feeding practices with the bottle and breastfeeding and how to get rid of that bottle by the year 1. Provide diet instruction. Talk about trauma and prevention to a parent so that they understand what happens, because there's going to be plenty of little kids that are going to fall when they're 3 and chip something. So at least they're aware of what's happening. Educate them so they understand. And if it's giving out a piece of paper that says what could happen like this, then so be it. Do your risk assessments and all of that. This is what happens at 6 to 12, at 12 to 24 months. You're still going over the same thing. The more times they hear it, the more they finally will get it. It'll sink in. And it could be done in a friendly, fun, manner. You can take any of these pictures and be creative on your computer, make pictures of it, show people what it is, show whatever it is. Again, I like that book, the Totally Disgusting, Gross and Disgusting book. This is what you're doing. You're talking about orthodontics by age 6. As soon as permanent teeth come in, you're talking about that stuff. And at 12, you're starting to talk about maybe more risk assessments, talking about third molars, talking about more education from a general dentist. We'll get into that, but I'm going to hold up this book that I don't know if you can post or you can even see. This book is basically called, if I hold it back up here, it's hard to see with my light, but it's Dentistry for Kids, Rethinking Your Dental Practice. I think I sent you a picture of that, guys. This is a great book and a reference guide to have if you're a general practitioner, because you can flip through it and see what to do for trauma, see what to do for caries risk assessment, see what to do with silver diamine fluoride, see how to do restore things, see how to actually work. It's a great book for staff, for general practitioners that actually want to do that. It's a great book for physicians. If you have the money and you're trying to promote your practice and you have a private practice, it's a great book to give that so they can look at it and use it as a reference. It's just a great, I helped edit it, I didn't write it, but it's a great book and I know the person that did that. It happens to be perfect. Radiographs, there is no timetable that's correct. Everybody is individual. So you have to take each child. I see a 3-year-old child. Now this is a kid that is like 2 years old and has virtually no teeth. So to take x-rays to me is foolish. I'm not going to see anything. You may disagree with me and that's fine. If a child has spaces and I can see interproximally, why am I taking x-rays? I'm not going to see anything. If in my case, I have a primary tooth that never had a permanent successor, it doesn't have any decay, so I don't have a permanent tooth. We noticed that when I got, an x-ray at age 8 or 9, whatever it was, it didn't exfoliate. Okay, so I know I need to take care of that tooth a little bit more. But the bottom line is, it wouldn't have made a difference if I knew at age 2, my mother still would have done the same thing that she did, or my parents would have still done the same thing that she did. How am I going to get x-rays? Well, sometimes that's difficult to do. You have to be creative. Sometimes doctors are horrible at doing that. Sometimes your staff member is superior. Some people that have, if you don't even have kids, you don't even have the compassion sometimes to work with that. If you have your own kid, all of a sudden life changes a little bit and you treat things a little bit differently. You can see people that don't have any kids because, sit there, I don't understand why they won't do this or why they won't do that. When you have a kid, you get it. When you have a kid with disabilities, you even understand even more. So you can take those pictures. We use, a snap array, a little film. You can take vertical bite wings with the snap array. You can take PAs. The kid doesn't even have to close. In this particular case, they're doing an upper PA where the child doesn't have to bite down. And it hurts when they bite down. If I can see interproximally, that's fine. It'll get me to where I need to get to. But pick that person in your office who is good, or pick your person in the clinic. You need to learn it as a dental student, but pick that person who is good that can help you with that. In my office, I also have a special needs coordinator. In the pediatric office, I have one of my assistants who has an autistic kid who understands what that is. She is my special needs coordinator, which means that she takes all of my patients who are special needs and she is responsible for them. When they call up the office or the clinic, they call up and they ask specifically for Desiree. Desiree knows how to handle them, knows how to take care of them, knows how to schedule them, knows what to say, and knows how to have some compassion because her kid is going through the same thing. So if you can afford to do that, or your clinic can afford to do that, even with somebody else, and it sounds better when they're saying, hey, I want the child to come in the morning or the afternoon or whatever. So the x-rays are not that difficult. Again, the snap array is there. You can take PAs. When I'm ready to do that, I will take an upper PA, a lower PA, and maybe 2 bite wings or 4 PAs if I need to do that. But you've got to size up each kid. There is no appropriate time. It should not be based on the patient's age, but after you review the individual's history and findings, you sit and you size everybody else. I can't emphasize this enough. Nothing is routine. Again, the Panorexes are standard, but that you can have some flexibility. All 3 of my kids are on different x-ray regimens. Again, the little one that has more decay gets more frequent pictures than my big one who has nothing, who will get them maybe every 2 years. So everything is based on the child. And sometimes you can't, sometimes you're not going to get x-rays until you get into the OR, and you're not going to know what you have and what your treatment plan is until you get into the OR, because that's the only way you're going to get x-rays on a special needs kid or a 2-year-old kid that has a bombed out mouth. You can make a good assessment and come up with a clinical idea of what's there, but don't over radiate and try to take pictures if you're not going to succeed. You'll figure it out. Again, that's, it comes with age, experience, time, and just a little patience. And again, I take good pictures, but my staff takes better pictures. And for some reason, they just, they're sweet. They know what they're doing. There's always one person that is better suited, and my girls will switch around and say, okay, this is a perfect patient for you because you can do this, and they'll get it. I don't take x-rays. There's some offices that take x-rays first. If you're following our guidelines and really the law, the doctor needs to prescribe the x-rays first. So to have somebody, and I understand the clinics, and I understand they go through x-rays first and whatever, but someone's got to look at the mouth, make an exam, and then say, hey, you know what? I want 2 bite wings, I want 2 PAs, and I'm done. Or I don't want anything. Don't automatically throw somebody in a chair and take x-rays for them just because that's your standard of care. That's just my opinion. Do whatever you want to do, but I think that's more appropriate. This is another picture that you can hand out. People today here, at least in the United States and in Europe, everybody argues over, I don't want any x-rays. I don't want any x-rays. I don't want any x-rays. They're dangerous. So we have to educate them. But the funny thing is they will never argue if your child falls on the ground, breaks his arm, and they take him to the hospital and the orthopedist says, I want 9 x-rays of that broken arm because I want to see what's there. The parent will say yes. And they don't put a lead apron on. They don't do anything. And then all of a sudden you come to the dental office and they say, I don't want to take any, I don't believe in x-rays. And you're talking about 1 x-ray, which is equivalent to nothing. And they'll argue with that. Sometimes you have to set that tone, and you have to set that tone at the beginning. And sometimes I know that I should take an x-ray, but I know that this parent is not going to accept that. And I'll say, okay, well, the next time we have to do that because that's the only way we're going to be able to treat your child. And sometimes you have to say, hey, this is not the right office for you. Or this is what we do. This is standard of care. We believe that this is what we're supposed to do. Here's guidelines again. It's another picture. I like to give this to patients, especially patients or parents that question everything. Well, here are the guidelines. I'm telling you that we individualize it. This is what we do. This is how we do it. And this is what we want to do. I don't know. How are you guys on time? We're like over 2.5 hours. You tell me. I got a little bit left. You want me to keep going?
Yeah, keep going, Professor. We are very pleased in your presentation, and our professors and specialists also are raising a question. I'm collecting them. Continue. Take your time.
Okay. All right. So what we're trying to do, I don't have that much more to go. What we're trying to do in the United States is mandate the cities to have exams before children start school. So when I lived back in New York, it was mandatory that a child, before they went into kindergarten, that they had to get a medical exam from the doctor, and they had to get a dental exam from the dentist, or else the school would not let them come into school. That way, they were trying to prevent decay from happening. A lot of nursery schools jumped on the bandwagon as well, and the nursery schools said, hey, we should do the same thing, because I lectured to a lot of nursery schools, and I said, hey, you should do the same thing. Again, we talked about learning. You cannot learn if you have a toothache. And the school, the dentist would sit there, and we would fill out the forms, and we would say the kid had decay and needed to come back. And we'd have to fill out the form at the end when the treatment was done, because the schools wanted to make sure that the kids were healthy, could learn, and both in body and in mouth. So the point is, it's great if you can get people to do this. You know, there were some other states that said, no, we can't do that. It's infringing on rights. It's up to the parent. I have a problem with that. I think it should be mandated. You know, it's just, you may not like vaccines, but they mandate in many states here that you have to have the smallpox vaccine, you have to have the chickenpox vaccine, you have to have the measles vaccine. And I'm sure when the coronavirus vaccine comes out, you will have to have the coronavirus vaccine. You get a flu shot. You can't come to school without those vaccines. You can't come to school without the measles, because there's been an enlarged, a great measles outbreak in the United States, because there are groups of people that don't want to take the vaccines. That's a political issue. I have no control over that. But I think that states should mandate, or countries should mandate, that a kid going into kindergarten or first grade, wherever you guys start, should have a health exam, because I want to know whether the kid's healthy. And they should have a dental exam. I don't think that it's too much to ask for. You know, if you're giving that for free at the dental clinics anyway, you can't say that it's a cost issue. So I think that it's essential. And again, seeing this little kid here, he's been to the dentist many times. He doesn't care. So for him, it's not a big deal. You know, but look how many kids you would have stopped from going to the OR, possibly at age 4 or 5, going into kindergarten, that you see decay processes starting, and maybe you can convince 20% of them more to get, you know, care done. You know, xylitol, xylitol is a naturally occurring plant product that is available everywhere, and it will help reduce the chances of, it changes the bacteria in your mouth. It will help change that bacteria and reduce decay. You have to use a little bit more than you think, but it comes in chewing gums. I used to have mints in my office. They were flavored grape and they were like sweet tarts. They were candies. The problem was that kids wanted to eat the whole can or the whole container. So I said to the parent, they can only have 2 or 3 a day. So there's gums, there's toothpaste with xylitol. If you're using toothpaste with xylitol in it, it has to be the number 1 or 2 ingredient. You may see in some toothpaste that they have kids who get aphthous ulcers. A lot of aphthous, that was a post that I just had. There's sodium laurate in the toothpaste, and sometimes that creates aphthous ulcers for some kids. But I look for toothpastes that have more xylitol in it, because one, they're a little bit sweeter. They may have fluoride in it, and the child will at least do that. He's more compliant and be able to get, you know, more toothpaste in them. Here's what you really need. It's another picture. You're not necessarily going to get 3 to 8 grams a day. The problem with having too much xylitol in your system is it can cause diarrhea. So you try not to get that much in there, but put all these things together: fluoride varnish, xylitol, green tea, drinking, or whatever it is. All those programs put together help create a package of a preventative plan. And that was the purpose of this lecture, is to create a preventative plan and educate. So these are all things that you do. I agree with them. Chewing gum is good. It's fine. But I'm neurotic. I don't like kids under the age of 4 chewing gum. I didn't even like my 10-year-old having a hot dog, because I thought I had to cut up the hot dog because they think I'm nuts. But I had to cut up the hot dog because I didn't want them choking. You know, little kids are gonna put anything in their mouth. I don't want them chewing gum. And you see it all the time. To me, I think it's crazy. So here is the evidence that there's accumulating evidence that daily dosages, if you can get that much in there, will reduce whether they're a lozenge or gum, syrup. You want to try to get it in 2 times a day, and they're available in all kinds of products.